This song's terrible. Sorry, I didn't mean to expose you to that. I didn't really know. I just thought yeah, it said heart attack in the name, so I thought it'd be cool. But failure. That sucked. Sorry, Demi. Or is it Demi? I don't know. Okay, we're working on the heart again. Let me hook up the mic. Oh, all right. So last time we left off with cardiac output and stroke volume and heart rates and all those kinds of good things. So we're going to revisit that to begin here, where we're talking about how the heart rate is manipulated. And there's one special law called Starling's law of the heart, which is basically also known as the rubber band law, which says that when the cardiac muscles are stretched and you let them go, they snap even harder. So the further you stretch the rubber band, the further you stretch the muscles, the harder the contraction is going to be. And so that affects stroke volume. Of course, the more you stretch the heart, the stronger the push, and thus the greater the stroke volume slightly. Because otherwise the stroke volume usually remains basically the same, and you typically just manipulate cardiac output by manipulating the heart rate. Okay, so how can you manipulate the heart rate? Well, we touched on this previously in the last slide. You increase the heart rate through the sympathetic nervous system, such as under stressful periods. This includes when you have very low blood pressure, you're going to increase heart rate because you don't have as much blood flowing through your arteries and veins. The hormones dealing with stress, including epinephrine, will trigger that, will trigger an increase of heart rate, as well as thyroxine. Exercise, as you know, would increase it, and then also decreased blood volume, which ties to low blood pressure, of course. Now, as far as decreasing the heart rate, the opposite, the parasympathetic nervous system triggers this. If you have very high blood pressure or high blood volume, you're going to slow down your heart. It doesn't need to pump as fast. And also, you're going to try to minimize or decrease the venous return, or the amount of blood returning through the veins. Now, let's talk about how blood flows through these arteries and veins. That's part of our next focus here. Blood goes from the heart through the aorta and then out to the arteries. Arterioles are mini arteries, and then capillaries. Capillaries go through the tissues, like the liver, for example. And then they come out as venules, which are teeny tiny veins, then veins, and then up to the vena cava. Now, arteries and veins both carry blood, but structurally they're slightly different. Okay, they both have a tunica interna, media, and externa. The media is always muscle, the middle layer. The externa is always connective tissue, and the interna is always going to be endothelial tissue. Okay. One of the major factors, though, is that major differences is that arteries have a much larger smooth muscle wall that you can see here, the tunica media. And as a result, they're able to manipulate blood pressure more significantly. They can vasoconstrict and they can vasodilate much more easily. And veins don't really do much at all. So in fact, the blood pressure in veins is very low, and the blood pressure in arteries is quite high. You'll also see that capillaries don't have the ability to do any of that. It's just connective tissue and endothelium. No smooth muscle whatsoever. So here again, tunica interna is endothelium, tunica media is the smooth muscle. It's much smaller in veins, and then tunica externa is connective tissue. Now, arteries, the walls are thicker. Lumens of the veins are larger, which means the space. So if you look here, the space carrying blood is larger, which also contributes to its lower blood pressure. And then the walls of capillaries are teeny tiny. The actual diameter of the capillary is 1 cell thick, so only one red blood cell can pass through at a time. And this is actually advantageous because this promotes or helps with the loading of oxygen onto hemoglobin and the removal of oxygen, and thus loading of CO2, but mostly removal of oxygen there at the tissues. Now, moving blood through arteries is easy because the blood pressure is pretty high. But in veins, it's more significant, or it's more difficult, because veins lack blood pressure. And this is especially true of the legs. It's really hard for blood to flow against gravity up through the veins because the heart is not playing as much of a role anymore. So veins are actually equipped with these valves every so often along the length of the vein. And this helps to prevent blood flow from moving backwards and only moves in one direction. So as blood moves from this region up into here, this valve will close, and then it moves up into this region, this valve will close. So it moves in these chunks. And part of the reason, or the movement of the blood, is done by the milking action of the muscles. Milking. That, you can add that to the dance that we created, the pieces earlier. Every unit we seem to have a different component to the dance. This one is milking, milking, and you have to say milking that way. Capillaries depends on if you want blood to go to that tissue or not. Okay, so let's say I am running and exercising, and I don't want blood flow going to my stomach. So what I'm going to do is I'm going to create a vascular shunt where I'm going to take these sphincters here and I'm going to close off the blood supply to all these, to this capillary bed. So blood basically just flows straight through and into the veins because I don't want blood going to my stomach. I don't need to digest food and do all that stuff when I'm running. On the other hand, if this is my calf muscle, my gluteus, my gastrocnemius, the precapillary sphincters are open to enable the blood to flow through these capillaries and through the tissues, thus dropping off oxygen at the muscle tissue and feeding it and so on. And capillaries are so thin that gas exchange occurs really easily across the membrane, both oxygen and CO2 coming back into the blood. Now there's one interesting thing with the fetus and how blood flows that I wanted to show you. I think this is one of the cooler things of the unit. Because a fetus doesn't use its lungs are actually compressed and it's floating in fluid. It's almost like a tadpole, if you like. There's a specialized structure in a fetus called the ductus arteriosus, or sometimes called the patent ductus arteriosus. Now it's a little hard to see with everything going on here, but I want you to focus in right here where my mouse is moving and look at this little structure here. This is not normal. Once the baby is born, this is going to close up, okay? This is a tube that exists during fetal development between the pulmonary artery and the aorta. Because we don't need or want blood going off to the lungs because they're not functioning, we don't want to waste that time and deal with trying to load oxygen in the lungs because that doesn't work. It's already oxygenated. The blood that's going through the pulmonary artery has already been oxygenated by the mudder, and thus the connection between the pulmonary artery and aorta makes for improved efficiency. Now blood is going to go straight to the aorta and then out to the rest of the body instead of going to the lungs. Super interesting thing in the fetus. Sometimes babies are born with this and it doesn't close and they have to have open heart surgery, although now there's probably other techniques besides cracking open the chest. But in general, sometimes this can stay open. It's disadvantageous once the lungs are functioning. This blood going through the ductus arteriosus is going to be deoxygenated, and you're going to get mixing of deoxygenated and oxygenated blood, much the same way as if you had, for example, a hole in the septal wall here. This is the septum, the separation between left and right ventricles. If you had a hole in there, that passing is going to cause the same kind of problem. Okay. Your pulse. So we all know taking pulse here, we can take our pulse here. Basically, the closer you take your pulse to the heart, the stronger the pulse is going to be and the more accurate in that way. Pulse is just measured in regions where arteries are very close to the surface. You're not going to check your pulse in veins because, again, there's very little blood pressure. And your pulse is just this bolus of blood that has been squeezed out of the heart all at once, flowing through your arteries, and it pushes the walls of your arteries out and then down, and you can feel that specifically. You all know you're not supposed to take pulse with your thumb, because if you take pulse with your thumb, then you're going to double up your pulse reading because your thumb has its own very strong pulse. Now, blood pressure, you all know a sphygmomanometer, that blood pressure cuff. The real name is sphygmomanometer, and it measures blood pressure, systolic and diastolic. Again, systolic is the pressure that's highest in the heart when the ventricles contract. Diastolic is the lowest pressure in the ventricles when they are completely relaxed. And again, the further away you get from the heart, the lower the pressure goes, all the way from arteries through capillaries and then into veins at the lowest. So here's how the blood pressure cuff works. You see your major artery here. This is the brachial artery going through your arm. Blood pressure cuff squeezes and cuts off blood supply to your arm. You leave it on there long enough, no blood's going to go down to your arm. Your cells will die. You'll have a arm attack. But then you slowly let the pressure, the air, out of the little baggie. And once the pressure inside your artery is greater than the cuff pressure, it's going to overwhelm it, and a little bit of blood is going to come through. And as a result, you're going to have the first reading of blood pressure, which is the systolic pressure. That's the highest pressure. And you're going to hear a sound because the blood flowing through this artery is very, very turbulent. They call it turbulent flow, which is like a river with lots and lots of rocks in it. It's very loud and rushing. It's a river rapids. And then as time goes on, the artery wall, which was shrunk down, now extends back out because there's no pressure acting on the outside of it. And then it's back to normal. Now we have laminar flow, as it's called, or slowed down flow or quiet flow going through. You don't hear anything else in the stethoscope that this person's using, the doctor here. And then, when you don't hear the sounds anymore, this is the diastolic pressure, no sounds audible. Okay, that's a sphygmomanometer. How do pressures differ? You can see in measurements, systolic and diastolic. This is in the aorta, which we don't really take because you're not measuring the aorta, you're measuring an artery, which is more in this region. But on average, a healthy individual is going to be 120 over 80, or 120 over 90 in this case is being shown. And as you get, again, further away from the heart, the blood pressure decreases till the vena cava is almost at zero. There's a lot of factors that affect blood pressure. The autonomic nervous system, we know, affects it sympathetic and parasympathetic. The amount you pee out will affect your blood volume, so these are renal factors that are mentioned there. Temperature, if you get really hot, you vasodilate, so your blood vessels get bigger, bring more blood flow to the surface in your extremities so you can sweat out and remove out that heat. And if you're cold, you vasoconstrict, you shrink down your blood vessels. Don't send as much blood to your extremities and to the surface to keep all the blood in your core where it's most important. And then various chemicals can increase or decrease your blood pressure, of course. And then your diet can also have a significant effect. This is all those things combined in a nice, beautiful chart showing you vasoconstriction. Exercise, of course, activates your nervous system, and it's going to increase blood pressure through vasoconstriction. Blood pressure goes up is the end result you can see here, and so on. So you can take a look at that chart there on your own. Normal range for blood pressure for systolic is 110 to 140. Anywhere in there is healthy. And 75 or 80 is diastolic. It doesn't change much from that. Even in unhealthy individuals, it doesn't go significantly from that. Now, if you have low systolic blood pressure, we call that hypotension. That can be very dangerous. Hypotension can kill you within a few minutes to hours. And hypertension, which is high systolic pressure over 140, can be dangerous long term. It can overwork your heart and you can have a heart attack or heart failure. But it's more long term. It's not immediate danger. Now, let's take a pause on this and we'll go to part B shortly. Take a little breaky.